This will wait a second until we have slightly more attendance and get going.
Doctor passed both Barty and Tony on medications. Just want to tell you.
I can't hear you, Christina. What'd you say?
Can you hear me now?
A little bit, yeah.
Sorry, I'm not sure why my headphones are working, but I said that both Barty and Tony are on medication.
Ah, okay, got it. All right, I guess we'll just go with the three of us. Good. All right, so you're in the emergency department and you see this rhythm. And my question to you is, what is the treatment of choice?
This looks like VT, but there's polymorphic. I'm curious if the patient is stable or unstable.
Patient is sitting and talking to you. They feel
Perf-
palpitations, but they are, as they say, smoking and joking.
Perfect. So in that case, I would want to establish IV access, and for stable, what looks like polymorphic VT, start some IV meds. I think I'd probably go with amio to start, but could also consider lidocaine. I know that we have those often available on call for these patients if if we have any suspicion they're at risk of VT. And then we'd probably want to give some magnesium as well, just to ensure that this doesn't progress into torsades or anything.
So that's certainly a possibility of what this is, and I think treating it that way would not be wrong. But what this actually is it's pre-excited atrial fibrillation in the setting of WPW. So whenever you see so first thing to say is what you recommended was absolutely reasonable, Vlad. So I would totally agree with that. But what this is rapidly conducted AF. We looked at an example of this, I think, 2 weeks ago. And so when you see this, when you see a wide, complex, irregularly irregular rhythm, um, you should always keep that in the back mind of your mind. So, so you could give amio. Probably a more proper answer might be procainamide in this case. Why is procainamide a good idea in pre-excited AFib? Proc works well because uh, it causes a lengthening in the effective refractory period of accessory pathways. So pathways that can conduct very rapidly when a person uh, is in tachycardia normally may start to conduct very slowly in the setting of proc. In the old days, before the advent of ablation, so in the 80s and 70s, when somebody would present with this type of rhythm, so the treatment of choice would probably be to sedate and cardiovert the patient. Second best would be procainamide. Third best would be amio. I think they're all reasonable answers, honestly, and I would be disappointed if a question offered all three as options. But because they're all reasonable options. And considering this to be, the thing about polymorphic VT is usually it's in the setting of long QT syndrome, and the QT in this case is not particularly long on the few beats where you can see it. It's admittedly a crappy tracing, but sometimes this is all you're going to get, when you're on call and somebody from an ER faxes something to you. And so the treatment of choice would probably be to cardiovert, followed by cardiovert or defibrillate, really, because you would defibrillate. And how much energy would you give the patient? How many
Sorry,
joules?
Dr. Bess, I just joined. This is AFib, right? If it's AFib, it's
Right.
0.5 to 1.
It's AFib with rapid conduction.
Yeah, it's a 0.5 to 1 joules per kilo.
That's right. And that's probably the most important reason why it's useful to know whether it's AFib or polymorphic VT. This could certainly degenerate into something like VT or VF, which is why people, we think, die with WPW. Actually, we know that's why they die. And would this be a synchronized cardioversion or an asynchronous cardioversion?
So I think it will be synchronized.
That's right. It is synchronized. What are you synchronizing to?
I'm sorry, I was muted to the V.
Yes, to the V. And why is that important?
Because if it's asynchronized, it might land in a T wave.
Yeah, that's exactly right. You can cause VF in somebody if you put the shock on a T wave. So you do want to do this synchronized. Now, the key when you're synchronizing this type of arrhythmia is sometimes the device may have difficulty in detecting the QRS. And it may take, you may press the button and there may be a delay in the delivery of a shock by a couple of seconds. And there are certainly many examples of people who have pressed the button, have not seen a shock delivered, and then have inappropriately and dangerously gone to the patient to figure out if maybe the pads are not attached to the patient adequately, and then they themselves have gotten shocked by touching the patient. So it's always important that when you press the defibrillation or the cardioversion button, that you do not touch the patient until the shock has been delivered. And if the shock has not been delivered and you're not sure why, you have to turn off the defibrillator temporarily or turn it off from the defibrillation mode and just into the monitoring mode. And then you can touch the patient. But it's very, very, very important to never touch the patient once you press the button, because particularly when you're doing a defibrillation or a cardioversion of a patient like this, you absolutely can there can be a pause even as long as 5 or 6 seconds, and it may seem like, because normally if you're defibrillating someone, the device will deliver the shock the second you press the button, whereas with a synchronized cardioversion, it's going to wait until it feels confident that it can see the QRSs. Now, one way to try to avoid that is to look at the monitor of the defibrillator to make sure that there's a little dot over every QRS, which is a sign that the defibrillator is easily reading the QRS. And the way that defibrillators are programmed, it's interesting, but the sensing on them is usually excellent. They use very good filters, and so it's even sometimes easier to see what a rhythm is on a defibrillator's readout than it is on a surface ECG, which is kind of interesting. Anyway, that's enough about this tracing. Any questions about this? Move forward. All right, this is a newborn. You're called to the nursery because the patient has a slow heart rate. So what do you think is going on? And is any treatment, needed?
Is this a long QT syndrome
Yes, yes,
with
it is.
so you have such a prolonged QT that when your atrial rate fires, the P waves are not conducted because the ventricles are so refractory?
That's exactly right. And so this is what is the QT interval here?
Just calculating it quickly.
Massive.
I got 920, so I think my calculation is wrong.
No, it's about 800. You're right. It could be longer than 800. This is one of the longest QT intervals, certainly that I've ever seen and possibly ever recorded. Um, this was a child who had. So, if you see a QT this long with 2-to-1 heart block, what is the most likely what is the most likely type of long QT that this is? It's not a guarantee, but most of the time when you see 2-to-1 block in a baby, a newborn, because the QT is so long. Do you have any sense of which of the genetic causes of long QT syndrome is the most likely?
Type 1?
No, it's actually type 3, long QT type 3, which is the sodium channelopathy. Now, again, I want to be clear. It could be any type, so it's not like it's a guarantee. But long QT type 3 often, or sodium channelopathy, SCN5A mutations are usually associated with these, can be associated with this type of really bad, extraordinarily long VT. And this patient, you can see that there are some PVCs here. This patient actually had tons of little runs of torsade that would stop and start spontaneously. So, okay, you're in the newborn nursery. Um, what could you do for this? Is there anything you can do for this? So you're seeing the little runs of torsade. So the NICU is saying to you, we don't like this. Can you do something to stop it? What about amiodarone? Patients having runs of torsade. Any thoughts
I
on?
would not give amio.
Okay, I agree with that statement.
It
Why?
can make things worse. Amio can prolong the QT.
Yeah, amio in part works by prolonging the QT, by prolonging repolarization. That's one of, it's one of these things where a little bit is good, a lot is bad. So in someone who already has a QT this long, amio would be strictly contraindicated. This is, by the way, one of the reasons why I've never been thrilled with the PAL's recommendation of giving amio to people who are having VT in pediatric practice, because in peds, the likelihood that it's related to long QT is much greater than it is in other areas where it is extremely unusual, like an adult who's having an MI, for example. So yeah, amio would be very bad. Is there any other agent you could potentially try here?
Well, if this is typically, I think of a beta blocker for long QT, but if this is the type 3, as you mentioned, I think it's, what is it? Mexilatine is a good agent for the sodium channel specifically.
Yes, so mixilotine could be a good idea, but this patient is having runs of torsade, and you're not sure how stable they are. So, is there any intravenous agent that you might be able to use?
Should you try sotalol
Well,
or
no, no. Why would
esmolol?
sotalol be a bad idea?
I guess because it has the effects on the potassium channels, and this is a type 1 or 2. You want to avoid it. So maybe a more
Well, yeah, I
pure
mean,
beta
it
blocker is
also
better.
works in part by lengthening the QT, right? It
So,
does.
so pure class 2 agents, maybe like a esmolol.
Right. So esmolol would be a reasonable option. Some people might try esmolol. Some people would be a little frightened of that because the heart rate is already slow, but paradoxically, lowering the atrial rate through esmolol might actually enhance conduction. Um, any other options? So I agree, esmolol would not be unreasonable. So let's say you give esmolol and the Torsades a little better, but you're still having episodes of Torsades, so you're not happy. You don't have adequate control. So another option would be to give lidocaine, right? Because lidocaine is also a sodium channel blocking agent, and there are reports of lidocaine being effective in people who have lung QT type 3. So when people have lung QT type 3, there is a little bit of a debate about whether beta blockade is useful. Most experts would give beta blockers to lung QT3 patients. If for any other reason than that propranolol is a very weak sodium channel blocking agent as well, but there is some soft evidence that it may be of benefit. I think it's up in the air, but I think most EP doctors would give beta blockers. But uh, this is a case where you might want to try lidocaine. In this case, what we did was we gave a dose of 1 milligram per kilo of lidocaine. Because now remember, you don't get genetic testing, right, for a few weeks. At the time this baby was born, this is now about 15 years ago, it could take 6 weeks to get the genetic results back. And so, sorry, yes, so Ivana is saying possibly Lido. Yes, so it could take 6 weeks to get the results back. So what we would do is we gave a dose of Lido, and before our eyes, within a minute, the QT interval shortened to about 500 milliseconds. And there was one-to-one conduction, which was really extraordinary. It was so extraordinary that we actually published this case and put the child on high-dose lidocaine, eventually transitioned them to a combination of mexiletine and propranolol, and also put in a dual chamber ICD in this baby. It was actually at the time the smallest infant ever to get a dual chamber ICD. It was an abdominal implant, and that device successfully defibrillated the patient over 60 times. Obviously, I'm not proud of the fact that he needed 60 shocks, but unfortunately, he needed very, very high doses of mexiletine to maintain a QT short enough to have one-to-one conduction. We tried pacing him. Some reports have shown that pacing can shorten the QT in some patients. Bottom line is, it's always a challenge with mexiletine because mexiletine lowers your seizure threshold. And unfortunately, this boy had a lot of seizures anytime he'd have any kind of fever related to the fact that he was on very high doses of mexiletine. And if he was like missed a dose, he would basically have torsade. So in retrospect, perhaps we should have transplanted him. I don't know. We had long periods of arrhythmia-free life. Ultimately, unfortunately, he passed related to mexiletine and seizures and anoxic brain injury, but not actually from torsade or ventricular arrhythmias. When he was in his, I think he was 8 years old, 8 or 9 years old. So the bottom line is, if you see someone with long QT, you don't want to give anything like amiodarone. I think esmolol is a reasonable option. Lidocaine is an idea. Now, some sodium channelopathies do not respond to lidocaine and respond to flecainide. So if there was no response to lidocaine, an alternative option or another option would be to try a small dose of enteral flecainide to see if the QT shortened. Interestingly enough, this patient had experimental studies done on his cells showing that another agent, ranolazine, which is another sodium channel blocking agent, was very effective at turning off these channels. Unfortunately, it only comes in a very long-acting compound, and we were frightened to give it to a baby because the company refused to give us any information regarding what would happen if we took a time-release capsule and gave the baby a small amount of it. And so we were frightened to do that. So we never did it. But maybe that would have been the right option. Okay, so this is when you see a patient with 2-to-1 heart block from long QT, you're in deep weeds. That is one of the worst, most difficult cases to manage. It's associated with a high mortality rate. And I think Molly Shaw at CHOP wrote a paper on patients presenting with 2-to-1 heart block in the setting of long QT, demonstrating that although some do well, it's a very difficult diagnosis. Any questions?
The best the degree of block is dependent on the how long the QT is, right?
Yeah, because basically the repolarization is so long in these patients. You know, putting a pacemaker in this patient is not going to work. In other words, you might say, well, it would be nice if his heart rate were faster. If you would put a V wire in and just started pacing without any therapy, in other words, leaving the QT where it is, the patient will not capture on, if you paste it, say, twice the rate that we're looking at here, the patient is just going to have non-capture on the alternate beats. When I was a fellow, there was a patient like this at Columbia, and I was a fellow in Boston, and I remember I went on a fixed-wing aircraft to pick that baby up and take them to Boston for further therapy, and they had put a pacemaker in the child, and were not having capture. And it was because I think there was a lack of appreciation of how you basically can't capture if you're still repolarizing with a gigantic QT interval. Ultimately, the way we managed that patient was an interesting choice, which is we pace the atrium at a very fast rate at like 180 and got 2-to-1 conduction, which resulted in a ventricular rate of 90. And so it was a sort of a way of increasing the ventricular rate. Was also treated with aggressive mexiletine and beta blockade, and apparently did pretty well. I think may still be alive. So he's now in their 20s. Any questions? Okay. All right. This is a post-op AV canal baby, 1.5 years old. What is this rhythm? Let's say we're like post-op day 1 in the morning. Any thoughts?
Dr. Cross is a junctional rhythm.
I agree. Why is it junctional rhythm?
Um,
How do you know that?
but I don't really see any P waves looking through all the leads, and then the R to R interval is regular. Um, and set.
Well, there are little P waves, right? If you look in V1, could convince yourself maybe that there's a P wave before each QRS. What do you think? Maybe. But
Yeah.
but these P waves, the PR is so short, right? That it's
Yes.
unlikely that this is conducting. So what would we call this when the P waves are not conducting, but they're beating at almost the same exact rate as the ventricle? It's called isosynchronous beating, where now if the atrial rate were slightly faster, it might be more obvious that there is a P wave, obviously, before every QRS. But this is probably junctional rhythm. Now, is this common or uncommon following an AV canal repair?
It could be common following an AV canal repair.
It's true. AV canal patients, for reasons that I'm not 100% sure, will get sinus slowing, particularly in the early post-op period. It's very common that you need to atrially pace AV canal patients after open heart surgery to repair the canal. They do not, in my experience, develop long-term sinus node dysfunction any more than any other congenital heart patient. But in the immediate post-op period, we do see a lot of sinus slowing and the need for atrial pacing. And I've tried to sort of think about why that might be. The only thing that I can come up with is that when the surgeon is doing an AV canal repair, there needs to be a tremendous amount of exposure, right? Because you have to be able to look at the entire AV area from the right to the left side of the heart. And so there's a lot of retraction on the atrium in order to properly expose the VSD, the ASD, the AV valve, common AV valve. So I suspect that probably because of the need for really good exposure to get a good repair, there's probably more inflammation around the sinus node related to retractors and pushing things out of the way in order to see what they're doing, because it's obviously a difficult and extensive repair that requires a lot of exposure. So that's been in my mind, I'm thinking that's probably the most common reason. There may be something that a surgeon could tell us that I'm not aware of. But it's very common that they have sinus node dysfunction, which in my experience resolves within 2 or 3 days. All right. Let me just see, do one more. Okay. This is a 19-year-old who comes in with syncope. What is the diagnosis and how would you manage this? What do we think? Any takers?
I'm not confident in this one, but is it a flutter patient with variable conduction?
Well, there is an atrial arrhythmia and there is variable conduction, but I don't think it's flutter. I think you're saying it's flutter because it kind of looks like there's P wave,
Yeah.
right?
And it
But
looks like the P waves are maybe, I can convince myself they're maybe the same size as whatever this baseline artifact is.
right.
It's hard to tease out.
So this could be artifact, or this could be, when you see an irregular rhythm with an atrial arrhythmia, the first thing that should hit you in your head is you should say, is this or is this not atrial fibrillation?
Right.
So, and you have to, the burden of proof, I would say, is on you as the cardiologist to decide whether it's AFib or not. In other words, if someone just called me on the phone, I'm on call, like in, let's say in 1992, and someone calls me and I don't have a fax machine and there's no cell phones that take pictures, and they say, we're here with a 19-year-old who's having an irregular narrow QRS tachycardia with a lot of P waves, I would probably say the chance of it being AFib is very, very, very high. And if you really look here in this area here, I think you could convince yourself that the P waves are all over the place. Now, I understand that this could also represent artifact, but the fact that there's this irregularity in the R to R interval suggests that there is something strange going on in the atrium. So this is actually AFib. Now, do we need to rate control this patient?
I don't think so.
Yeah, no, because the heart rate is not very fast, right? So if we were going to rate control, we could give either esmolol or diltiazem or something like that. But in this particular case, the ventricular escape rate is not particularly fast. So I think we would not need to rate control. But if this happened, let's say it's 6:30 on Friday night, and you really can't gather anybody to do a cardioversion at that time, what would you do for overnight coverage of this patient? You would admit the patient. Anything else that would that you would do to provide protection while you're monitoring the patient for the morning? So let's say you call you can't figure out when this started, so you need a TE, right, to rule out the possibility of a thrombus in the heart, because you don't know how long the patient has been in it. But you can't really get that all. The patient had a cheeseburger at 5:30 just before they walked into the ER, so you don't feel comfortable sedating the patient, so it needs to be done in the morning. Is there anything other than admitting to the ICU, putting them on telemetry, that you would do for this patient?
Would you anticoagulate?
Absolutely. You would anticoagulate the patient because the biggest risk of this arrhythmia, right, is the development of a thrombus and a stroke. So yeah, you would put this patient on unfractionated IV heparin and get a therapeutic PTT on this patient quickly to sort of stop the clock on the chances of someone getting, a thrombus in their heart and having a stroke. The other thing that you would probably do is do a transthoracic echo. Now, transthoracic echo will not rule out the presence of a thrombus. However, it could rule in the presence of a thrombus. If, for example, you did a transthoracic echo and you felt confident that you saw a large thrombus in either the right or the left atria, you would manage this very differently than if you didn't. So it's not so good at ruling it out, pretty good at ruling it in. If you saw a big thrombus in the left atrium, you wouldn't need to do the sedation and the cardioversion. You would instead change course and put the patient on something like warfarin or a NOAC or a DOAC, and then leave them in AFib for a period of 6 to 8 weeks to allow the anticoagulant to dissolve the thrombus. In the old days, and this is probably just precedes my time as a physician, it was very common if someone had AFib to just put them on an anticoagulant, put them on an AV nodal blocking agent, and send them home for 6 weeks. And then you would just bring them back and and then cardiovert them without a TE. It was really only in the mid to late 1990s that it became clear that a TE was reasonably good, not perfect, but reasonably good at ruling out thrombus, and that you could accelerate the whole process by just doing a TE and a cardioversion. But it's not unreasonable, especially if there's a contraindication to sedation or an intubation, to put the patient on an anticoagulant, let them go home for a couple of weeks, and then bring them back and cardiovert them after they've been on enough. Because it's been shown that if you're on for 6 to 8 weeks of warfarin at therapeutic range, most thrombi will dissolve in that setting. Okay, I think any questions? If not, we'll stop for today. All right. I hope everyone has a wonderful day.
Thank you.
Thank you.
Thank you.